Hi and welcome. My name is Elaine Gonzalez, community educator at the Breast Cancer Resource Center in Austin, Texas. Today, we will be discussing essential questions before surgery. I'm grateful to have with us Dr. Sangeetha Kolluri. After receiving her medical doctorate at the New York Institute of Technology, College of Osteopathic Medicine, Dr. Kolluri completed her residency in general surgery in Flushing Hospital Medical Center and completed fellowship in breast surgical oncology at Texas Tech University Health Science Center. She is a fellowship-trained board-certified breast surgeon, exclusively focused on breast cancer and benign breast disease with expertise in lumpectomies, mastectomies, port insertions, ultrasound core needle biopsies. She is certified by the American Society of Breast Surgeons for the performance of breast ultrasound. She has a special interest in hereditary genetic syndromes and peripartum breast cancer. Dr. Kolluri is an active member of the American Osteopathic Association, American Society of Breast Surgeons, and fellow of the American College of Osteopathic Surgeons, FACOS. She is the founder of Inclusive Breastfeeding Dr. Mom Group on social media and is the founding partner of Wildflower Breast Center in Austin and Kyle, Texas. Dr. Kolluri, thank you so much for joining me today.
Well, thank you for having me. It's an honor.
Well, great. Let's get started with some questions. And so first off, would you mind explaining briefly lumpectomy versus mastectomy?
Absolutely. So broadly speaking, in the treatment of breast cancer, we have two options for how we're going to take a tumor out. So the first option, of course, is to remove the entire breast mound. We call that a mastectomy. The second option is one of breast conservation, where you can just remove the area of the cancer with a rim of breast tissue around it for a negative margin, keeping the remainder of the breast mound intact. Colloquially, we call this a lumpectomy. The billing term, because sometimes there's confusion about this, we actually call it a partial mastectomy, but it's not removing your breast, it's a lumpectomy for breast cancer.
Great, thank you, because that question comes up a lot, partial mastectomy. I appreciate you saying that. So I want to ask about a mastectomy. Does having a mastectomy mean there is no breast tissue left?
No, it does. There is in fact breast tissue left behind after a mastectomy. And this is one of the most common misconceptions about a mastectomy. It would make sense to think that, hey, I removed my breast, there should be no breast tissue left behind. Unfortunately, from an anatomic standpoint, that's not possible. So we all have a certain amount of body fat that lives under our skin. We call that subcutaneous fat. And there's not actually a very clear line separating the fat that belongs to your skin from the fat that belongs to the breast. So when we do a mastectomy, we are leaving behind 2 to 5% of the breast tissue. And from that 2 to 5% left behind, breast cancer can and does come back at the same rate as if you had chosen breast conservation.
So then if a patient chooses a mastectomy, does that lower the chance for recurrence since there is less breast tissue?
There's no difference in the recurrence rate when you compare that with breast conservation with a lumpectomy followed by radiation. So what we mean by that when we say recurrence, we actually have two categories. We talk about local recurrence, meaning cancer returning somewhere here on the chest, or distant recurrence, meaning the cancer has returned in a different body part outside the breast, such as the brain, the liver, the lungs, the bone. So those are distant recurrences. When you compare these two options, they have the same rate of local recurrence. They have the same rate of distant recurrence. They are considered comparable. Okay. So there is no significant advantage from the standpoint of recurrence to a mastectomy. Now, this information that I'm sharing assumes that you have negative genetic testing. So that assumes that you're not positive for any of the inherited genetic breast and ovarian cancer syndrome mutations, such as BRCA1, BRCA2, PALB2, and so on.
So if a tumor is found in the same breast or in the other breast, does that mean that is a recurrence or is that a different cancer?
Okay. If the cancer happens on your second breast, opposite the original cancer site, we would not call that a recurrence of cancer. It's a whole new cancer with a whole new tumor biology. Now, that tumor biology might be similar to what happened the first time around, but it could easily be a very different tumor biology. In both circumstances, we would not call it a recurrence because that breast is a whole new breast. So think of it this way. These two breasts, they're not twins. They're just neighbors. They just happen to live next door to each other. Cancer doesn't spread from one breast to the other. If it happens on the other breast, it's a whole new cancer. It's a little tougher of a question to answer when you have a cancer in the same breast a few years after the first event. If it is a similar tumor biology, we could probably reasonably say that it is a recurrence of the same cancer. You can have circumstances, however, where the original cancer recurred and the tumor biology has changed because this cancer has acquired more mutation. So it may represent the same cancer, but it looks like a different disease process. So it's a little bit of a harder question to answer, and it's going to hinge on the individual tumor biology and presentation in that patient with their recurrence.
Good to know. I think a lot of people assume that it travels. And so a lot of times that's why they choose mastectomy, because I don't want it to travel to the other breast.
That is correct. There is no evidence that removing your healthy breast changes your survival rate at all. In fact, the Choosing Wisely campaign stipulates that we should not routinely remove a healthy breast. Now, are there good reasons to remove a healthy breast at time of treatment for your cancer side? Absolutely. There are good reasons to do it. So this is not to say that we're against double mastectomies. It's just to say that we have to make sure that we understand, so to speak, what we're buying with our money. We're not buying a cancer-free future. We're not buying a change in survival rate. We are buying freedom from mammograms going forward. We may, depending on the individual patient, be getting a better, more superior cosmetic outcome, and that's going to hinge on the type of reconstruction you're pursuing.
Okay, so I want to go back to what, because you just mentioned, are there situations where a mastectomy would be best?
Yes. Now, I'm going to preface this by saying that ultimately, this is the decision on mastectomy versus lumpectomy should hinge on the conversation that you have with your surgeon. And that should include review of the radiology, review of the pathology. Does that match what it feels like on clinical examination? There's a lot of interplay here. But generally speaking, times where we would think about a mastectomy is if we have a situation where there's a large burden of disease, and that large burden of disease either could not be decreased in size with medication, or we tried medication to decrease the size and that didn't work for us as well as we like, then we may have to do a mastectomy to remove the full volume of disease. If the tumor is in close to the nipple, some patients may elect to have a mastectomy because if they may reason that, hey, if I'm losing my nipple, I would rather just remove the entire breast for cosmetic purposes. And that's a completely valid choice. If the patient has had a recurrence of cancer in the same breast, they may say, at this point, I prefer to proceed with a mastectomy and remove the entire breast mound, especially if that recurrence has occurred within a few years of the original event. That's not necessarily the case if the recurrence is happening 20 years later. You may then be a candidate for a repeat lumpectomy in that circumstance. You don't have to get a mastectomy, even after radiation. Other indications would be if the patient is desiring to forego radiology surveillance going forward. So if you're doing a mastectomy, you're doing that with the understanding that mammography in a screening setting is not indicated once you've had a mastectomy on that side. Even though we do have that tiny rim of breast tissue left behind after the mastectomy, there's no data that supports the annual mammogram as catching a recurrence faster than clinical inspection. So we don't recommend annual screening mammogram. For the same reason, we don't recommend a screening ultrasound, and the data is very, very mixed on screening breast MRI after mastectomy, because the problem is that MRI has significant false positive rate. And so you're more likely to pick up false positives like fat necrosis, benign stuff, rather than to catch an actual recurrence. So with the understanding that if you're wanting to do a mammogram and you understand that you won't be doing that kind of imaging anymore, and you feel good about not having to do that kind of imaging anymore, then a mastectomy may be the right choice for you. Other indications would be if the patient is wishing to forego radiation after lumpectomy. Generally speaking, we pair the lumpectomy with radiation. There's a few exceptions to that, but generally, if you're doing a lumpectomy, you're shaking hands and saying you're going to do your radiation. If you choose a mastectomy, assuming that your tumor is small and no nodes are involved and we can get negative margins, then most likely you'd be able to avoid radiation. So if a patient is wishing to avoid radiation, the mastectomy may be the better choice for them.
Okay, well, great. So it's good to know, I think knowing radiation, really knowing how you feel about radiation and getting that information before making a decision either way.
Now, it's worth pointing out that a mastectomy doesn't guarantee freedom from radiation. In the end, we're making all these plans before we go to the operating room. We're doing the best of what we can with the information that we have before we go to the operating room. But a huge chunk of information is going to come to us after surgery, and that's the final pathology report. And that's crucial because the plan could change based on that final report. So if we discover that, hey, lymph nodes are positive and we thought that they weren't going to be, that could buy you radiation after mastectomy.
Okay.
This is an example. So I usually will say to patients, I'm not a betting person. I wouldn't bet $5, but maybe I'll bet $1 that you may be able to skip radiation if you happen to go the direction of the mastectomy, but I make no guarantees. It's also important to think that, to realize that there's no surgery that buys you out of chemotherapy. And that's another common misconception. If I go down the route of a double mastectomy, maybe I can buy myself out of chemotherapy. The way that I describe it is the tumor makes some decisions and the patient gets to make some decisions. The patient gets to decide, especially in an early breast cancer situation where we caught it early, we don't think lymph nodes are involved. In that situation, the patient can decide which surgery they wish to go with. And with that decision comes a decision to pursue radiation. So if you're choosing a lumpectomy, that means you're choosing radiation to go with it. If you're choosing a mastectomy, there's a good chance you'll be able to avoid the radiation. But the decision on what medications you need, including chemotherapy, the tumor makes that decision. That's how I kind of frame it. Because the tumor biology is what's going to indicate which kinds of medications we need. And those medications may include chemotherapy, may include immunotherapy. So there's no surgery that buys you out of that decision.
So really getting the facts and not basing decision off of fear and emotions, because it seems to me that there's a lot of great data and a lot of mostly clear information. I know sometimes it's not so clear, but it seems to me like really getting that information first before basing decision off of, like I said, fear and emotion.
Yeah, I completely agree. And, the fear that breast cancer patients experience comes from so many different sources. Part of it, of course, is your own personal emotions on the topic. Part of it's going to be your family members and your friends and their concerns, your kids and their concerns. Part of it is, let's put it right on the table, financial concerns. That's a big one. And so we need to be, as surgeons, recognizing what these challenges are that our patients come with, where their fears are coming from, and then address that head on and say, let's make a decision. Acknowledging those fears, talking about those fears, but not letting them drive the decision-making process. And let's use kind of a level-headed approach so we can really ask the right questions to get to the essence of what is it that you're after in going forward. And one thing that, pretty much all breast cancer patients want is to be cancer-free. In both situations, we have the same chance of remaining cancer-free. If one was significantly better than the other, why would we even offer the second option, right? They're equally good in options. And actually, increasingly, some data is suggesting a slight survival advantage to the lumpectomy, which is the opposite of what a lot of patients think it would be. Why is there a slight survival advantage to the lumpectomy? We're not really sure, to be honest with you. And it may actually be as simple as Patients who choose to have a lumpectomy are showing up to their doctor's visits a little bit more often. It may be that, hey, they're showing up for the mammogram because they've agreed to get that mammogram once a year. They're participating in the healthcare system. So should a recurrence happen, and remember, it happens at the same rate, lumpectomy versus mastectomy, maybe it's just that we have the chance to catch it sooner. It's unclear why that's the case. So I wouldn't necessarily tell a patient to choose a lumpectomy based on that very slight survival difference. And the data on that is still mixed. But what we want to focus on is, what are we trying to get out of this experience? I know you're going to be okay at the end of this road in 1 year, but what's that going to look like 1 year from now, 5 years from now, 10 years from now? That's our goal. I'm already thinking to the 5-year ahead mark. How do I get you to that place where this experience, we can try to make it a blip on the radar. We can try to make it a small part of your life rather than the dominating event. And a big part of that is asking the right questions as a surgeon. So for me in my office, that means asking nuanced questions about what the patient's relationship to their breasts were before a breast cancer diagnosis. So I, kind of pose it to them and say, hey, listen, let's talk about this. Before all of this happened, how did you feel about your breasts? It's a really weird question, right? It's a tough question.
Yes.
And it's one that women don't get asked this question. I've never been asked this question. But think about it, because we have so many emotions about our body and especially about our breasts. And yet this question has never been asked. So I kind of pose it to them as, there's how you feel about your breasts in terms of appearance, in terms of your relationship to breast sensation. Is it important to you to feel your kids or your family when you hug them at night? Or is that not important to you? Is it important to you to have breast sensation when you're having sex? For some people, it's crucially important for arousal. Other people, it genuinely doesn't matter to them. Okay, everybody's going to be different. How do you feel about getting mammograms going forward? There are patients where the mammogram caught this breast cancer, they never felt it, and they're going, my goodness, thank goodness I got that mammogram, and I feel so great about the idea of going for that mammogram every year. I want that objective test once a year to check me and make sure that there's no cancer. Okay. Other patients may not have had a very good relationship with mammography. Maybe they felt poked and prodded and they didn't really enjoy that experience. Maybe the idea of going for an annual mammogram once a year really frightens them and would augment their anxiety. We're not here to add anxiety. We're here to make this experience better and tailor it to the patient's needs. So if going for the annual mammogram is going to really terrify you and you're just going to be miserable having to go for that test once a year, that's a good reason to pick the mastectomy. That's a totally valid reason. On the flip side, if we're not going to have the ability to do mammograms going forward and you wanted that test once a year, that's an argument for a lumpectomy. If sensation matters to you, that's an argument for a lumpectomy. If it genuinely never mattered to you, it's never going to matter to you, that's an argument for a mastectomy. So you can see how the same information can go two different ways, because it's not about the best surgery. It's about what the best surgery is for the patient. And only the patient can answer that, but only if the surgeon asks the right questions.
Right. Very individual, very personal decision.
Very individual. Yes.
Yeah. I want to go back to talking about a lumpectomy for a minute. What is oncoplasty? And will the surgeon be able to perform this procedure, or does the patient need to see a plastic surgeon?
This is one of my favorite topics. Okay, so oncoplasty has to do with rearranging breast tissue to minimize the defect. So when we talk about surgical treatment for breast cancer, I think generally everybody's familiar with, hey, if you have a mastectomy, you'll be offered the option of implant-based reconstruction or autologous flap reconstruction, which means taking your own tissue to reconstruct the breast, which is typically done as a deep flap. A third option of reconstruction after mastectomy is aesthetic flat closure, going flat. But many times patients forget that actually plastic techniques can be used in the lumpectomy setting. And that's actually crucially important to be offered that for every breast cancer patient, irrespective of which cancer surgery they choose. So oncoplasty can be like a level 1 oncoplasty, which would mean rearranging the breast tissue to minimize the defect, sometimes with the assistance of a small device, which can help to minimize the defect and also mark this area for radiation. Because remember, you shook hands and said, you're going to do your radiation if you did a lumpectomy. It can also be, sort of medium levels, or if you have minor, we call it ptosis, which is the nice, the medical term for droopy breast tissue, which some people, lots of us have. So that can also be done, as it can be combined with a lift. If I have a patient who struggles with terrible back pain from very, very large breasts, many times they may come in asking for a mastectomy, saying, I just want relief from my back pain because of these large breasts. And we say, hey, what about a lumpectomy and a breast reduction? You don't have to lose your breast to get the relief on your back. We could do a lumpectomy and a breast reduction and lift. And that allows you the option of saving your breast tissue to continue mammography. If that's something you wanted to do, you got that lumpectomy. You also got rid of a lot of that breast tissue. All of this is covered by insurance. That's the wonderful thing, because once you have a breast cancer diagnosis, it's no longer considered cosmetic. Now it's considered reconstructive. Now, what your surgeon's going to be able to offer to you is going to hinge on their individual skill set. So I can't speak for every breast surgeon in America. Everybody comes to the table with different skill sets. So this is something that you want to ask about. What will you do to help to minimize the defect if I choose to go the route of lumpectomy? What concerns do you have, Dr. So-and-so, about the cosmetic outcome based on where my tumor is, based on the volume of breast tissue that I have, maybe based on whether your breast tissue is not so droopy or is more droopy, and also proximity to the nipple. What are the techniques that your surgeon employs to help to minimize this defect? Are they proficient in things like rearranging the tissue and minimizing the defect? Some breast surgeons do their own reductions in this setting. Some breast surgeons prefer to partner with plastic surgeons, both of which are very valid choices. And that's something that you'll want to explore with your surgeon and find out how do they navigate that. But I do think it's important to choose a surgeon that's comfortable exploring all the options with you, not just taking out the breast cancer and leaving a defect. Because right now in the breast cancer world, this is where the standard is that we should be able to perform these techniques for our patients.
Great. Can you just briefly, because you use the word defect, so
Yes,
can you explain what you mean by defect?
Yes, I can. So let's go back to a moment to the word lumpectomy. So lumpectomy, now in surgery, every procedure we do has a code. We call it a CPT code, okay? So lumpectomy is actually coded differently. That's when we have, okay, here's a teenager, she's got a benign breast mass and it hurts and it's big, and every time she has a period, it hurts. Okay, it needs to come out because it's bothering her. In that situation, because it's a benign breast mass, it looks like a hard-boiled egg. Think of it like a hard-boiled egg. It's got very smooth edges all the way around. It has like a little capsule to it. So when we take out that mass, it's almost going to come out like a hard-boiled egg from the shell. It comes out very easy. There's no defect left behind. There's no hole left behind. Because as that benign breast mass started to grow, all it did was push aside breast tissue. It didn't invade the breast tissue. So this is breast disease by interpretive dance by Dr. Kolluri. So breast masses, when they're benign, they grow like this with smooth edges all the way around. Okay. When breast cancers grow, they grow like this, with tentacles in every direction, and my feet are sticking out too. And so because of that, we have to take a rim of healthy breast to make sure that we remove the entire area of disease. And it's actually technically a little bit of a difficult thing to do, and you have to really think when you're in there operating in this case. You have to kind of use your noggin as a surgeon as you're doing a lumpectomy. But that because you're cutting into healthy breast tissue, there is going to be a defect or a small hole left behind by this procedure. So the breast surgeon should be able to employ techniques to minimize that defect and rearrange the tissue to minimize the defect. Now, it's never going to be as if you never had surgery, because of course we did do surgery, but can we make this cosmetically optimal for you? Absolutely, we can try to do that. And that can include rearranging the tissue. Some people utilize Biosorb. That's one of the things that I use in my practice is Biosorb, which is an implantable device, and it actually dissolves over the course of 2 to 3 years and marks the area for radiation. So it kind of, kills a couple birds with one stone. Some people partner with plastic surgeons to do the lumpectomy and reduction, and all of these are very valid options. So it's just something that you want to talk to your surgeon about. Is there is going to be a small defect. How large do we expect this defect to be based on my tumor size? What are the challenges that you anticipate in this situation? And how can we address that proactively?
Dr. Kolluri, you wrote a blog for BCRC titled "What's Best for Breast? Essential Questions Before Surgery." In the blog, you wrote, "There is not statistically significant difference between having a lumpectomy with radiation versus mastectomy. Many physicians use the term no difference in survival rate when discussing surgery options. Would you explain why it is explained this way? Mm-hmm. And does this mean survival within 5 years with no recurrence or lifetime?"
Okay, that's a great question. So when we talk about lumpectomy versus mastectomy, we're talking about 3 different metrics, right? So the first one is local recurrence, which is cancer coming back on our breast or chest wall. These 2 are equal in that outcome, okay? The second one is cancer coming back in a different body part. We call that distant recurrence. Again, these 2 are equal in that outcome, okay? The third one is what we would call overall survival, meaning, okay, when you're going to live your life to the end of your days, because we're all going to, have the end of our days, how long is it going to take you to get there when we compare the lumpectomy versus the mastectomy? And this is where, on the whole, we have said that these are equal in overall survival. And whatever it is that at the end of your life, happens to be the cause of your death, that's more or less the same in both groups. Now, this is where we are starting to see some data suggest a very slight survival advantage to patients who chose breast conservation, the lumpectomy, which is sometimes the opposite of what breast cancer patients think it would be. They think the mastectomy is going to buy them the safer outcome. And it may actually simply be that lumpectomy patients are slightly more likely to continue to participate in the overall healthcare system and, show up for appointments and see their doctors. And in doing so, if they noticed something new changing on their breast or chest wall, that they're more likely to report that than perhaps a patient who's undergone a mastectomy. This isn't to say that somehow mastectomy patients don't show up and get care. Obviously they do. But it may simply be that patients who have chosen a lumpectomy because they are, for example, showing up for a mammogram. If you've had a mastectomy, you're not getting a mammogram on that side. It's another opportunity for them to speak up should they notice something strange. And so it may simply lead to slightly quicker detection of recurrences should they happen. But again, that's a total guess. We don't actually know the answer as to why there's a slight survival advantage. I think the moral of the story here is not necessarily pick a lumpectomy or pick a mastectomy based on survival. I think the moral of the story here is, regardless of which surgery you ultimately pick, you want to make sure that you are doing your job, which is breast or chest wall self-awareness, and that's crucial. So what we are talking about is not diagnosing a breast mass, not diagnosing a recurrence. That's my job as the surgeon. What we're talking about is, what can you as the patient do to be the expert of your body in an empowering way? So if you have a native breast, we call that breast self-awareness. If you've had a mastectomy, we'd call it chest wall self-awareness. And that includes the visual inspection of memorizing on your healthy breast what this normal appearance is of your healthy breast. On your treated side, memorizing, hey, where are my incisions? What do they look like? Maybe if I've had radiation, what are the radiation changes? What does that look like? Maybe if I've had some type of reconstruction, whatever form of reconstruction that may be, what does that look like? What does it feel like? Okay. We're not going to call that memorizing the new normal, because there's nothing normal about it. You've been treated for cancer, but it is a new baseline. So training your eyes to know what to look for, training your hands to know what this new texture is, what is the feel of it, getting to know those scars that you have, those incisions, because we see you a couple times a year. And as much as I'm a professional expert, I don't live with your chest 365 days a year. You do. Mm-hmm. So knowing your body, knowing how you've healed, knowing the treatment changes that have taken place, and also on your healthy breast, if you still have one, that's crucially important. And that's called self-awareness. That's, I think, the moral of the story here is, whichever surgery you pick, self-awareness is crucial.
Great. And so that helps overall survival rate, because the sooner, if there was a recurrence, the sooner we catch it, the better the survival rate would be.
That's very much true. The better, and the more options we have for treating it. If we catch a recurrence and it's a very tiny local recurrence, yeah, we have some options as to how we can treat it. The longer a recurrence sits without us knowing about it, of course, it becomes harder and harder to treat. And that's the moral of the story with breast cancer itself, right? The earlier we catch it, the more options we have for treatment and the easier it is to get to that cure rate that we're all hoping for. Now, your job, like I said, is not to diagnose what this breast mass is or to realize that it's a recurrence. Your job is just to say, hey, listen, I know my body. I know my native breast. I know my chest wall. I know what my incisions look like. Something is different. And I know because I've been checking. There's a skin dimple here that wasn't there before. I'm going to see my surgeon and have them check it out for me. Then we'll take it from there. You're going to come into our office and we're going to say, okay, let's investigate this further. That's my job, is to diagnose what's actually going on here. And a lot of times the changes that you're noticing may not be cancer recurrence. It could be as simple as just an evolving scar. It could be fat necrosis. It could be something else that's benign altogether. But we just need to have the information from you of exactly what are we dealing with so that we can take it from there.
Okay. Right. Great advice.
Yeah.
So in the blog, you also suggest a patient meet with a medical oncologist before surgery. So are you suggesting the patient be referred to a medical oncologist with any diagnosis and size of tumor?
Yes.
And what if the surgeon doesn't refer the patient to a medical oncologist?
Okay. Put me on the spot. All right. Let's dive into that.
Just a little bit.
So in the treatment of breast cancer, we have 3 doctors who are primarily involved in the treatment of this cancer. Okay. The first job is the surgeon. Their job is to take the cancer out. The second job is a medical oncologist. Their job is all the medicines to treat this breast cancer. Sometimes that means chemotherapy. Sometimes it means immunotherapy. Sometimes it means anti-estrogen pills. We call that endocrine therapy. Sometimes it means a combination of these, okay? And the third doctor is the radiation oncologist, not to be confused with the radiologist. I know those are similar terms. The radiologist is the person who's reading your mammogram and reading your ultrasound and reading your MRI. The radiation oncologist is an oncologist who uses radiation energy to treat the breast or chest wall. And all 3 of us work together as a team. Now, in the world of breast cancer, not everybody needs surgery, not everybody needs chemo, not everybody needs radiation. In an early stage breast cancer diagnosis, there are some decisions that the tumor makes, like I said, and there are some decisions that you, the patient, get to make. So I do recommend, I generally think that it's important to loop in the medical oncologist early on in the process. Now, if what you have is a relatively small, early stage estrogen positive breast cancer, and your breast surgeon does not think that this tumor is a super aggressive tumor, it's reasonable to meet the medical oncologist after surgery is done. If we're planning a lumpectomy or planning a mastectomy, I think that's a reasonable course of action. But I would say the indications where I would feel very strongly about the patient meeting medical oncology before we proceed with surgical treatment would be tumor greater than 2 centimeters in size, more than 1 site of cancer, if a lymph node is positive for cancer, if the tumor biology is estrogen negative, if this tumor is triple negative, if it's HER2 positive. Those are all indications where I would say I really do think this patient should meet medical oncology first, because in those situations, the likelihood of needing to have treatment before surgery rather than treatment after surgery goes up. And I do want this patient to get all their options and to get the perspective from all the members of the team before I put knife to skin. I don't mind being a little bit firm about that and saying, I really think that that is essential. And if you're in the position of meeting with a surgeon who didn't happen to send the referral at the first visit, that's okay. You can reach back and say, I'd like a referral to medical oncology. I'd like to meet them now before I proceed with surgery. It's okay to say that. And it's okay to push for that if you need to. But I do think that a responsible surgeon, and I think all of us here in the community are pretty responsible, I think a responsible breast surgeon is going to make sure that they are sending that referral up front. And they're going to ask you about Who would you have in mind and what kind of personality are you looking for? Just like breast surgeons, we all have different personalities. Medical oncologists have different personalities. Some patients feel strongly about wanting a certain gender of physician. Some people want someone closer to home. Some people want someone with more of an academic bent. Some people want someone who is more of a breast medical oncology specialist. Some people want someone who's more of a generalist. Some people may say, hey, someone close to me that I love had a great experience with Dr. So-and-so, and I want to see that person. Okay. So this is a conversation that I think should be part of the initial breast cancer consultation with your surgeon.
So it's okay to advocate for ourselves.
I would say it's essential to advocate for yourself. Essential. And the title of the blog is Essential Questions Before Surgery. So I would say that this is an essential conversation. Now, if what you have is like listen, it's a 1 centimeter estrogen positive, slow growing tumor biology, it's okay to then say you'll meet the medical oncologist after surgery. I would still say that that's safe to do. It's a question to ask your surgeon. But I would say that if you have a large tumor, say greater than 2 centimeters, or lymph nodes involved, and the surgeon's wanting you to take you to surgery first, that may be the right decision. I don't know. I can't speak to your circumstance. But in that case, make sure you meet the medical oncologist just to make sure you're getting their perspective before you go to surgery, because the medical oncologist may say, hey, wait a minute, actually, I have a different suggestion. Perhaps we should do medical treatments before surgery. And that is increasingly a very valid choice, because sometimes there's a lot of advantages to doing medicines before surgery, including potentially shrinking the tumor before we go to surgery. Wouldn't that be nice? So we just want to be sure that all the members of the team are looped in and thinking together as a team, because this is a team-based approach. We should all be working together on your behalf.
Yes, agree. And I think in our community, we have some wonderful doctors that do just that. So
we really do. I'm very lucky that I get to work here. It's awesome.
Yeah. Okay. In the blog, you also mentioned genetic testing.
Yes.
So
one of my favorite topics.
Yes, I know. Should a patient have genetic testing with all stages of breast cancer diagnosis? And does a patient need to see a genetic counselor?
Oh, okay. All right. So this has been an evolving topic. And so I'm going to kind of give you a little bit of the history that goes with this. Okay. So the short answer is yes, every person with a diagnosis of breast cancer should be at least offered the option of genetic testing. And that is easily drawn. It can be done with blood or with saliva as a test, and it takes a couple of weeks to come around to turn around and come back with results. And that's easy for any breast surgeon to do. It's easy for the medical oncologist to do. I mean, even a gynecologist, they're very comfortable drawing these things too. But usually in the cancer setting, the surgical team or the medical oncology team is the team that's drawing it. There's been some changes that have taken place with regards to genetic testing. So that's why I want to dive into that a little bit, because what people may have been told in past may now be out of date. So let's start with genetic testing as a term. And I'm glad you said genetic testing and not BRCA testing. BRCA testing is actually an out of date term. And it refers to when the genetic test that was commercially available only tested 2 things, BRCA1 and BRCA2. Nowadays, we know about lots of other hereditary syndromes like PALB2 and CHEK2 and Li-Fraumeni syndrome and Cowden syndrome and so on and so forth. So because we now know that there are more syndromes out there, we recommend doing genetic panel testing, which is checking BRCA1, BRCA2, plus a bunch more. So if you had testing more than 10 years ago, you should go back and get retesting of a full panel, and that will get you up to date, okay? Now, the reason why we had more strict criteria in the past is because when that first test came out, it was charging something like $3,600 a pop. And insurance companies were kind of balking at paying that amount of money. So NCCN, this is a critical name to know. This is a governing body for all oncologists, including surgeons. And they had to come up with a list of criteria to try to force insurance companies to pay for genetic testing. So they kind of said, okay, look, who is the highest risk of the high risk people that we see that we can say this person needs genetic testing? And so those are the NCCN guidelines for genetic panel testing. And over the years, they expand the criteria and expand the criteria and expand the criteria as we discover more and more and more indications for genetic testing. In the meantime, the cost of genetic testing has plummeted. So from $3,600
Nowadays, the cash price with no insurance involvement at all is $249 max. That's with no insurance. Your insurance may actually cover that $249 depending on your insurance policy. And some patients, if they have certain income-based criteria, may meet criteria for as little as $100. So that's a big difference from $3,600.
Wow. Yes.
Not only that, but genetic testing in the beginning was not widely available. Now it's easily available. We can even mail kits to people. It's not a big deal. So the American Society of Breast Surgeons came out, and I want to say it was 2019, and they said, we disagree with NCCN. All those reasons for having strict criteria for genetic testing no longer apply in their view. And so they came out and said, we feel that all breast cancer patients, irrespective of age, irrespective of family history, should be offered genetic testing. Doesn't mean you have to do it, but should at least be offered. It should be part of the discussion. And in doing so, I changed my practice since those guidelines came out in 2019, and I started offering it to everybody. And I caught hereditary syndromes on patients that didn't meet NCCN criteria. This is controversial. Every breast surgeon is going to feel differently, but I do think that there's a significant advantage and at much, much, much lower cost. And the other thing is that the best person to test is the one with breast cancer. So I want to offer that while the patient is in my office, because it does help us for surgery planning. We want to know if that genetic testing is going to be negative before I say to the patient, hey, I think a lumpectomy is a safe choice for you. And it's nice if we can get that back, because then let's say we had a surprise finding of a BRCA mutation, we may then decide that we want to change our surgical plan to a double mastectomy. And in that situation, we now have the ability to change that plan and make it suit the patient's needs.
So if you can do this testing or the medical oncologist or the OBGYN, then genetic counseling is not necessary?
I would say, so I'm gonna word this carefully, because first of all, genetics counselors, certified genetics counselors are amazing people. They are an outstanding resource, but we have a shortage nationally. We have a shortage in Texas. We have a shortage in Austin. So access to genetics counselors is not actually that easy to get. And meanwhile, most genetic testing companies actually offer access to a genetics counselor through their company for free as part of the testing. Okay. So you can get access to that counseling in more than one way, but you don't have to see a genetics counselor to get genetic testing. A qualified fellowship-trained breast surgeon should be more than capable to draw that testing themselves and counsel you on it. That's what we do. That's what we're trained for. A medical oncologist can draw it. If you have a gynecologist who's motivated, they can draw it. And not only that, but when you get your testing back, if need be, you can pursue the conversation with the genetics counselor afterwards. But in my view, if a doctor is ordering the test, they should be qualified and prepared to have that discussion with you about the findings. And I bring that up because there are actually 3 possible findings in genetic testing. Patients are usually only aware of 2 possibilities. So possibility number 1, we found a legitimate mutation. Okay, that's a conversation by itself. Possibility number 2, the testing was negative. And by the way, most people are going to test negative, even if they have a terrible family history, even if they had a young breast cancer diagnosis, most people will test negative. And that simply reflects that right now, our technology has X amount of panel, that's X number of genes that we are checking. Obviously, that's evolved from the old BRCA test that only checked 2 things. So today, if someone walks in with a BRCA test, we're going to throw it in the trash can and get the updated test. So what are we going to say 20 years from today about today's test? Oh, what a piece of crap this test is. Now we have this new test, which is 1,000 genes or whatever they have in the future along with spaceships. So, so in that situation, now we'll be updating the testing. So we can only do the best of what we can do with today's technology. But most people today, even with all of our updated technology, even with a bad family history, even with a young breast cancer diagnosis, most people will test negative for a pathogenic mutation. The third possibility, and it's crucial that your doctor tell you this before they order genetic testing, is a variant of unknown significance. We call this a VUS. This is crucial to understand. When we talk about variants in genes, a gene is a set of instructions. This is how you make hair. This is how you make skin. This is how you make an eyeball. These are all coded for in our genes. A mutation means the information in that gene is broken. or corrupted. And now that set of instructions is telling your body to make tissue in a way that it's not supposed to. Now, most changes that happen in genes aren't actually harmful. And so if it's a non-harmful change, we call it a variant. A good example is hair color, right? If you look at humans around the world, we have lots of different hair colors. We have brown, black, red, et cetera, blonde, right? None of those are harmful. They're just differences in the color of your hair. So those are variants. Now, when they sequence the human genome and they're looking for all these areas, they identified variants. But the problem is that the research didn't catch up with the technology. So we don't know if those variants are cancer causing or not. So we call them variants of unknown significance. Now, the vast majority of VUSs are ultimately declared benign and not cancer causing. So if you test positive for a variant of unknown significance, we're going to treat you like it's negative. Okay, but we understand that the research is ongoing and will be updated. And if they update us down the road and say, hey, remember that variant? Turns out it is cancer causing. Okay, now we're going to update your plan of care from there. But most of the time, that doesn't happen. I can count on my hand twice ever in my career where I had that happen.
Oh, wow. Okay.
Yeah, out of thousands of genetic testing sets that I've sent.
Yeah, that's fascinating. I'm curious to see what happens in 20 years.
Yeah, it's a very exciting time for genetic testing. So I would say that, in my opinion, every breast cancer patient should at least be offered the option for genetic testing in accordance with the American Society of Breast Surgeons guidelines. If you didn't get offered that, it's okay to advocate for yourself and say, I would like to pursue this testing as per the ASBRS guidelines. And your breast surgeon or your medical oncologist or even your gynecologist should be able to help you.
Great. Excellent. So I'm going to go back to a question about surgery or this genetic testing. Will the cancer spread or will the tumor grow, while waiting to see all of these physicians and get all the testing done, and then also while waiting to receive these genetic testing results? So I know people have a lot of fear around it's taking so long. What is happening? I just want to get it out.
Yes. This is a very common concern, especially because also in order to prove your diagnosis, we had to do a needle biopsy, and often that area feels larger afterwards simply because of the swelling and the scarring that occurs from a needle biopsy. And and now you're focusing on it because now you know what it is. You're going, oh my gosh, now I'm monitoring it, it feels bigger. And it makes perfect sense to think, is this growing and dividing rapidly inside of me? Generally speaking, the answer is no. So technically speaking, from date of biopsy, we have 90 days to get the job done, either to do your surgery or to start medical oncology treatment, whichever one would be appropriate in your case. Now, obviously, nobody wants to take 90 days. We absolutely want to get this done much, much faster than that. But that tells us that we have some luxuries in breast cancer, unlike other cancers. We have the ability to do the workup and get all of our answers and get all of our ducks lined up before we go to the operating room, because we're not here to rush to the wrong surgery. We're here to figure out what the right course of action is. We have time to get more imaging if we need to. We have time to meet a medical oncologist. If we have to meet a plastic surgeon, we have time for that. We can make this happen. Now, we're not here to be blasé. I do want to get you in quickly. I do want to move on expeditiously. So we have a tough needle to thread. I'm going to give a lot of patients like a ton of homework when we first meet because, hey, I want you to meet this person. We're going to get the genetic testing cooking. Maybe I want an extra set of studies. Maybe I want you to meet a plastic surgeon. There's homework to be done here. But while you're doing that homework, the genetic testing is cooking. We're not losing any ground here. I have a rule with patients. What I tell them is, I'm not from Texas originally, confession. I'm from New Jersey, and it's not in my bones to be subtle. So I'll tell the patient, listen, I will tell you if I think this is an emergency. I will tell you if it's stop the press as we're going to the operating room. It's rare that I have to. There are a few circumstances where that may happen, but usually we don't have to. We have the ability to do the job right the first time. And breast cancer it's maybe helpful to remember, it's not a surgical emergency. It can be an emotional emergency, right? You found out that you got breast cancer and you're going, oh my God, my life and my work and my family and the money. And am I going to survive? Am I going to get to the other side? Do I got to have chemotherapy? Am I going to lose my breast? Oh, that's a lot. That's a lot.
Yeah.
And you're going, this is an emergency and I want this thing gone yesterday so I can move on with my life. Mm-hmm. That's a totally valid feeling. So this is not to say that somehow it's all in your head. It's not in your head. This is the reality. But we need to get more information so that we can get you to the other side. This isn't a circumstance where I see you on a Monday and I'm booking the surgery for Wednesday. We want to make sure we're doing the job right the first time. And sometimes that means getting more information. This is like a fact-finding mission. When you come in to meet the surgeon, we're going to answer a lot of questions. We're also going to raise some questions. Then we're going to meet the next doctor. They're going to answer more questions. They're going to raise more questions. And we're going to evolve our way towards an answer. And that big final answer is going to come from surgical pathology, because that's the elephant in the room. We all live and die by the surgical pathology. And that's one more doctor who's in your corner that you never meet, and they care so much about getting you the right answer. So all of this is designed as a process to get you the most accurate answer possible without losing ground with breast cancer treatment.
I love that answer. And I think a lot of patients, again, that fear just takes them over. So I love knowing that safely there is time.
Yes. Now, I would like to make one comment on this because it is related to this topic. I would like to make a comment about breast MRI. So breast MRI is a modality that is used to help assess breast tissue. Okay. It is not better than a mammogram. It is not worse than a mammogram. It is simply a different technology to look at breast tissue. Okay. And with the concern of how long is it going to take me to go to surgery, this is why it's relevant. Okay. There are indications to get an MRI. So indications for an MRI would be if you have a tumor biology that looks like it's in more than one area, if we think that there are lymph nodes involved, if we're worried that this tumor is close to the nipple, close to your skin, or close to your chest wall, those would be indications for an MRI. If you turn out to have a hereditary syndrome like BRCA, then that should get you an MRI as well to make sure that there's not more than one area of cancer. Another important one is if radiology is saying the mass is this big and clinically on exam it's this big, that doesn't match. When it doesn't match, we call it discordant, and that should get you an MRI as well. But the Choosing Wisely campaign clearly states that routine MRI should not be ordered for every breast cancer patient as part of surgical planning. And here's why. There was a great study presented at the American Society of Breast Surgeons. I want to say this was like 2021 when they presented it, that when you order a breast MRI, you are doubling how long it takes for this patient to go to the operating room. That's a huge deal, especially when patients are concerned about their cancer growing. Now, if we need the MRI because we have one of these scenarios that I just described, then we need the MRI because we want to make sure that we are getting a thorough job. This is not to say that we're anti-MRI. We obviously order lots of MRIs. But let's make sure that if we're ordering an MRI, we clearly understand why we're getting it, because it also has a high false positive rate. It also has the potential to delay when you get your surgical care. So let's make sure we have a clear understanding of what is our goal of getting this MRI. Is there a specific indication for getting this MRI? Is it because we're worried we're specifically worried that there's more than one area of cancer? Is it because there's a lymph node involved? Is it because there's a discordance? The radiology doesn't match the clinical exam. Is it because I have a hereditary syndrome? Is it because this tumor, listen, it's there, but you just can't see it on the mammogram? Wow, you just can't see it. Okay, that's an indication for an MRI. These are all really good reasons to get MRI. But routine ordering of a breast MRI is not recommended for every breast cancer patient in America. And the reason is because it delays your time to surgery. There is a cost of that.
I think I'm glad you brought that up because breast patients talk to each other and, always comparing treatments and diagnostics. And so I think that's a really good point to know that, again, it is individual.
Yes.
yes,
distinctly
to their specific cancer and their specific needs.
That's correct.
So I want to just ask, I think you briefly answered it, but I just want to kind of get it clarified. So if you order genetic testing in your office, once you get the results back, what are your next steps?
So my next step as a surgeon is, of course, we're going to note first. I need to see the results first as the surgeon and review the findings and make sure that I clearly understand what this report is saying. And then I or my team members will contact the patient to notify them of what the results are and provide a copy to them. I tend to use companies that make genetic counselors easily available. If there's any kind of question, of course, we can go to the genetics counselor. But if what we found was an actual pathogenic mutation, increasing your risk of cancer, I'm going to personally contact you because now we have a conversation that we have to have. I want to go over the data of what is this particular mutation? What was this gene supposed to be doing? What was its normal function that is now giving me a much higher risk of future cancer, including on my healthy side, than what it had been if I had tested negative? What other cancers am I at risk for? Many of these hereditary syndromes increase your risk of multiple other cancers. So now our picture just got a little more complicated because we may need to check out other body parts and balance that with, expediting your cancer treatment as well. We may now be in the position of needing to change our surgical plan. So let's say I have a patient who has a BRCA1 mutation that we identified. That may change our plan from lumpectomy to mastectomy, but I want to talk to them about it. I want to say, okay, here's the data. I want to go over with them what is their risk calculation of cancer on the healthy side. And those numbers are different than what I quoted them when we first met. Mm-hmm. I also want to calculate Ask to Me. Ask to Me is one of my favorite calculators on earth. All syndromes known to man evaluator. I think this is hilarious. And this is from Massachusetts General, which is Harvard. And it's a wonderful calculator that looks at pathogenic mutations. And you can input the patient's information and it's de-identified. You're just putting in the general features of the case. And then it's going to tell you what their risk of multiple other cancers are. So I want to go over those numbers with the patient. If I have to loop in other doctors, let's say they're BRCA positive, I may want to send them to a gynecologic oncologist for surveillance of their ovaries. Let's say it turns out that it's Cowden syndrome, they're at higher risk for colon cancer. Not immediately, but I may need to send them to a GI doctor to make sure that we're not also looking at a colon cancer at the same time. So there's a lot more nuance to this. And of course, I may want to send them to a plastic surgeon. If they opt to go down the road of double mastectomy, then we can talk about our options for reconstruction, whether aesthetic flat closure, implant-based reconstruction, or autologous flap reconstruction.
You didn't mention, but I'm assuming you also would loop in the medical oncologist.
Yes, I didn't mention that, but that's sort of a given for me.
Yes.
In my practice, okay. I'm overly communicative with every doctor. So I'm constantly messaging my colleagues to say, hey, here's the update on so-and-so. But yes, that would be a given, is that we also want to make sure we're looping in the medical oncologist. Also, by the way, the primary care doctor, who is like, the hero of medicine, the primary care doctor and the gynecologist, these are two hardworking folks. A lot of times all these developments are happening on the oncology side and they're kind of lost in the dust and never even knew what was going on. So I do make it a point to loop in primary care and gynecology and say, hey, here's the updates. I just want you to know what's going on.
I love that. I love that. So what are things that surgeons can do to make sure they are removing the tumor completely?
Oh, it's one of my favorite topics too. Okay. So the first thing when you're meeting with a surgeon, of course, there's imaging that was involved with your case. There was likely a mammogram, maybe there was an ultrasound. And so the surgeon shouldn't just be looking at the reports. They should also be looking at the images for themselves. They should have some experience with looking at a mammogram. And looking at an ultrasound, because sometimes we actually catch things that maybe radiology might not have mentioned. So for example, hey, your cancer is over here, and I'm looking at the mammogram and I say, hey, you know what, there's like a cluster of calcifications right by the nipple, and maybe it's nothing, but I want to pick up the phone and call this radiologist and say, hey, can you look at this and tell me if you see what I'm seeing, because I think I want to biopsy this area. Because we need to check that out and make sure there's not second sites of cancer before we proceed with surgery. We want to be as prepared as we can be. So your surgeon should be skilled and equipped to look at their own mammogram and read it, and skilled and equipped to look at the ultrasound. Ideally, they should be ultrasound capable and able to perform ultrasound in the office. Even though you're looking at ultrasound images from the radiology office, you get even more information from performing your own ultrasound in real time in the office. Now, not every breast cancer is ultrasound visible, but the ones that are or have an ultrasound visible clip, I will always ultrasound that patient myself because that gives me so much more information in real time. I'm also going to scan the axilla or armpit to make sure that there's not any lymph nodes that are suspicious for cancer. Once in a blue moon, I might catch a lymph node that's suspicious for cancer that might not have been flagged earlier. So I may say, hey, I want to proceed with doing a needle biopsy in my office and check that lymph node out because we don't want to miss that kind of situation. The second thing is that when we take out this, now we're going to the operating room, when we take out the cancer, I wish more people asked me how we orient the specimen. I don't think breast cancer patients know to ask this question. I don't think I would have known to ask this question if I wasn't actually a breast surgeon. But I think that this is such a crucial question. So when we take out any body part, a stomach, any body part, it's going to go down to the lab. And some body parts have inherent orientation. If you take out a stomach, you can clearly tell where the entry to the stomach and the exit to the stomach are, and everybody knows the shape of a stomach, right? It's got some inherent orientation to it. But once the pathologist slices that specimen up to make slides, because they do actually have to slice it and make very, very thin slides. Once they make slides that are little glass slides, they can't actually tell which direction was north and south and east and west. They don't know. So they have a trick. Before they slice it up, they use a paint kit. It's literally a kit of 6 colors, blue, red, yellow, green, orange, black. And they paint each side of the specimen. Each color indicates an orientation. Okay. And there's a code for this, right? And this code is not, the code may be different from hospital to hospital, but the point is, hey, here in Austin, for example, blue is superior, meaning towards the head, and green is inferior, meaning towards your feet, and so on and so forth. Every color has a code. Okay. Now, historically, when surgeons take out breast tissue, remember, especially when we're taking out a lump of breast tissue, it doesn't really have any inherent shape to it. It's a lump of breast tissue with fat. Okay. And some people's breast tissue really doesn't have a lot of structure to it, sort of like melting ice cream, it kind of splooshes and doesn't really hold its shape very well. So historically, surgeons would put one stitch on one side of the specimen and another stitch on another side of the specimen to say, hey, this is the orientation and this stitch is this direction and that stitch is that direction. But you didn't really, if you think about it, remember you took out a lumpectomy kind of like a cube, right? You didn't really tell them where the edges are. So the American Society of Breast Surgeons does recommend consideration of painting your own specimen in the operating room. I wouldn't say that putting a stitch here and a stitch there is wrong, but I would say that there is an easy way to do it that costs $0 to the patient, which is just to paint it yourself. And there are surgeons, us here in town, we all do this. And that provides tremendous amounts of information to the pathologist because they're not having to guess as to where the edges of the specimen are. Now they know because you've provided that information. And it takes 2 minutes and costs $0 and it's easy to do. And it's like fun arts and crafts in the operating room. So our staff thinks that they love it. They think it's fun. So that's something that I would say is a good question to ask is how is your surgeon orienting the specimen? And then partial with that is how are they confirming that this cancer is inside the specimen? So we do have these machines called specimen X-ray machines. Generally, I think all the hospitals in our area have them. But you want to ask, hey, is your surgeon actually using this machine right in the operating room? And it's actually a machine that's physically in the operating room that, okay, I've painted my specimen, great. And now I'm going to put it on a little grid or a little cup, and I'm going to put my specimen there. I'm going to put it in the machine and close the door and hit the button. And it's going to take an X-ray. So this doesn't have to go down to a radiologist to have a radiologist interpret it. I'm looking at it in real time and I'm comparing what I see on the picture to how I painted my specimen. And I'm critically confirming that the biopsy clip that radiology plays for us is in my specimen. That's my proof that I have removed the correct area. And I think that that's critically important for surgeons to be doing. So that's an important question to ask your surgeon is, how are they confirming that the specimen did contain your tumor? And how are they confirming that at least intraoperatively the margins are negative? What are they doing? In my practice, generally, I will send the specimen down to the pathology department to have them kind of eyeball it. Some cases we do it, some cases we don't. It's going to depend on the individual tumor biology and appearance. And then we go from there.
Wow,
but every surgeon should have a system of how they choose to do it. This is not to say that somehow my system is the only system. There's so many different ways to orient a specimen. Some people use charms, like they look like little bracelet charms, and they have little letters on them. And some people stitch the charms on, and they like that over painting. There's so many different ways to go about it. But you want to ask this question: how are you orienting the specimen? And how are you confirming that your specimen contained my cancer? In other words, how are you confirming you did the job correctly?
That's fascinating.
Yes, it is a fascinating
I had no
topic.
idea.
Yeah.
I've no, just out of curiosity, are those techniques fairly new, or have they been doing those techniques for a while?
Specimen X-ray has been around for quite some time. And these machines, like anything else, they get upgraded and the technology gets better and better. I think I'm at least the hospitals that I go to, every single one of them has a specimen X-ray machine, and we use it heavily. Painting is something that I think, I mean, if you ask a pathologist, they've been painting specimens forever. That's standard for what they do. But the concept of surgeons painting their own specimens, that's something that I trained in my own fellowship. That's something that we did. It was a part of my training. So I carried that to, my first practice was in San Antonio. So I carried that to San Antonio. They weren't doing that in that city at that time. And then, it came to Austin, and actually other surgeons here were doing it, which is great. And I love to see that. So I do think that it's spreading, especially because it's so easy to do and it costs so little money. It's very, very easy to do. But other people like to do charms, and charms are also a cool way of doing it. That's also a great option. There's pros and cons to all of these different options. Some people like the charms because the charms show up on an X-ray. Some people don't like them because the stitch can tear off, especially if your breast tissue is kind of fatty. Sometimes the stitch tears off by the time the pathologist got it, and that's annoying because it fell off. There's not a right or wrong to it. It's just what's your surgeon's process? Did they think about this? That's all we're after.
Yeah. Charms for a breast tumor. That's amazing.
Yeah. I personally like painting because I think painting is kind of gets right to the heart of what we're wanting to do, but everybody has a different technique.
Great. So then if a patient is interviewing a surgeon, should they base their decision on these technical skills?
I would say no, because technical skills are one crucial component of what the surgeon's going to offer to you as part of the consultation, is their expertise and their judgment and their technical skills. But there's another crucial component, which is, how did you feel with this human being, your surgeon? Did you feel like they were a part of your team? Did you feel like, should something unexpected happen, because let's face it, this is breast cancer, unexpected things can happen. If something unexpected happens, do you feel like this person is going to have your back? They're going to help you to navigate it. Are they going to help to get you to the other side? Are they going to follow you once you're on the other side? Do they have a program for survivorship to continue following you, and a plan for maintenance? Do they have, have they created a team that makes answering questions easy? Have they made themselves available? And some people want a surgeon who's within a team that's very, very large. They want that big box experience. That has pros and cons. Some people want a more intimate approach. My practice happens to be a little bit more of an intimate approach, where we want you to know everybody who's on the team and really get to know all the faces. But there's no one surgical approach that's right or wrong. Some surgeons are more touchy-feely, probably that's me. Some surgeons prefer to maintain a little bit more of a clinical distance. That's okay too. And it's a question of, how do you feel about your interaction with this person? Does it feel like they understand what you're after? They care about your goals of care? Do they care about shepherding you to the other side? Do they does it feel like, should something happen, should a complication occur, unexpected pathology finding, that they're going to be there with you to help you to navigate that? I think those are crucial aspects of selecting a surgeon. And by the way, I would say selecting any member of your cancer team.
Excellent advice. Excellent advice. This has been so helpful. I've learned so much, and I think anyone watching is going to learn a lot from today. So do you have any final thoughts to share with anyone facing a breast surgery decision?
Let's see. I would say, I think it's helpful to know what the job of the surgeon is. And in my view, my job as the surgeon is not just to cut out a breast cancer. My job is to stand, if you'll permit me the football analogy here, my job is to stand on the field as the quarterback and say, okay, here's the situation. I'm looking at the field. Here's what I see. And I see this challenge. I see that problem. We can try this play. We can try this play. We can try this play. But I don't own the team. The patient owns the team. It's ultimately the patient's decision what they want to do. Now, I'm going to present to you what I see. I'm going to present to you the data. I'm going to present to you the options. I'm going to say, hey, if we choose this avenue, there's these advantages, there are these challenges here that we may have to be prepared for, versus this direction. There's these challenges and there's these advantages that we may have to be prepared for, okay? And now I'm going to ask you, the owner of the team, the right questions to help us figure out, well, which direction should we take here, right? And as we go through this, right, it's not like I'm making one call and that's it, we're done, right? We're going to advance to the next step, and then we're going to advance to the next step, and then advance to the next step. And we're going to keep having this conversation. Relationship to a surgeon should be just that, a relationship. You should feel like your surgeon's got your back. You should feel like they care about how you do. And I think that it's critical to remember, though, that it's not my place to make the decision for you. My job is to present you with the information. I'm your employee. You don't work for me. I work for you. So I'm your employee. I'm going to present you with the data of what I think is safe, of what I think we can do, of what I think are some advantages and disadvantages of different directions that we can choose to take. And my job is to line you up for success. So I would say my final words to all the patients on here is pick physician members of your team who are going to take a similar approach. That's my bias, is pick people who are going to help you feel like you've been lined up for success. And should challenges happen, they're going to be there with you. If patients are trying to reach me, or if anybody's wanting more information, you can reach out. On my practice is Wildflower Breast Center. I am also on social media, and I try to provide education there too. I'm at Breast Texas, BREASTTEXAS, at Breast Texas. That's Instagram and on Twitter as well. And you can go to my website, which is wildflowerbreast.com.
Thank you, Dr. Kolluri, for joining us
much
today. I appreciate your time. Thanks for all you do for our breast cancer patients in our area, and we're so grateful.
I'm so grateful to BCRC for this opportunity. This was incredible. So thank you for your time.